Hello everybody, I'm Dr. Ahmed Fareed. I'm MD Cardiology and Fellow of European Association of Cardiovascular Imaging. I'm from South Canaan University, Egypt. My topic today will be about antithrombotic therapy in acute coronary syndromes, the in-hospital and the post-discharge. Antithrombotic treatment during and after acute coronary syndrome plays a key role in reducing adverse events, but poses serious difficulties owing to the delicate equilibrium between ischemia and bleeding risk. And patients with acute coronary syndrome are by definition at high ischemic risk, as their phenotype entails a tendency toward plaque rupture and vascular thrombosis. However, most also carry comorbidities that expose to an extensive risk of bleeding during antithrombotic therapy, which can equally impact the prognosis of these patients. And for this reason, treatment adjustment based on patient characteristic is advocated by international guidelines. As we all know, acute coronary syndrome could be classified into ST segment elevation myocardial infarction and non-ST segment elevation acute coronary syndrome. And as we all know that in ST segment elevation, the difference is the initiation of the reperfusion therapy, which is not the case of the non-ST segment elevation acute coronary syndromes. If we want to talk about antithrombotics, we can broadly stratify them into three categories: fibrinolytics, antiplatelets, and anticoagulants. The anticoagulants are like the heparin and low molecular weight heparin, direct thrombin inhibitors like the bivaloridin, and factor X inhibitors like the fondaparinux, and the newer oral anticoagulants. For the antiplatelets, we have the aspirin, the clopidogrel, the prasugrel, and the ticagrelor, and abciximab, eptifibatide, and the tirofiban. For the fibrinolytics, we have the streptokinase, urokinase, alteplase, retiplase, and tenecteplase. As an approach to start an antithrombotic treatment in patients with acute coronary syndrome, you should always weigh the risk of ischemic risk versus the bleeding risk, and you should keep these in mind: patient characteristics, the clinical presentation of the patient, the associated comorbidities, the co-medications that the patient are taking, and the procedural aspects. Either the patient will go through a coronary angiography, PCI, or coronary artery bypass graft. Let's start by the ST segment elevation myocardial infarction. And as we had said, that the main target here is the reperfusion, and this could be done either by the primary PCI or with the fibrinolytics. So the use of antithrombotics in ST segment elevation will include the three types: the fibrinolytics, the antiplatelets, and the anticoagulants. Let's start with the fibrinolytics. If the reperfusion therapy is indicated in all patients with symptoms of ischemia with ST segment elevation, if it is less or equal to 12 hours with persistent ST segment elevation. A primary PCI strategy is the recommended over fibrinolysis within the indicated time frames. So if it is possible, you should go with the primary PCI. But if primary PCI cannot be performed timely after ST segment elevation diagnosis, fibrinolytic therapy is recommended within 12 hours of symptoms. And when fibrinolysis is the reperfusion strategy, it's recommended to initiate this treatment as soon as possible after the ST segment elevation myocardial infarction diagnosis. And the fibrin-specific agent like the tenecteplase, alteplase, or retiplase is the recommended over streptokinase or urokinase, which are older generations of fibrinolytics. So, as we had said, we have the streptokinase, which we can use a 1.5 million units over 30 to 60 minutes. The alteplase, which we can use 15 milligram IV bolus followed by 0.75 milligram per kg over 30 minutes and up to 50 milligrams, then 0.5 milligram per kg over 60 minutes. Or tenecteplase, which is a single IV bolus depending on the patient weight. It's less than 60, 60, 70, 70, 80, 80, 90, and over 90 kg. You should also be aware of the contraindication to thrombolytics. We have absolute contraindications like prior intracranial hemorrhage, known cerebral AV malformations, known cerebral neoplasms, ischemic stroke within 3 months, suspected aortic dissection, and active bleeding or bleeding that it is excluding the menses, and significant trauma within the past 3 months. There is some relative contraindications with severe uncontrolled blood pressure over 180 over 100, prolonged more than 10 minutes CPR, history of prior ischemic stroke more than 3 months, and major surgery in less than 3 weeks, recent intracranial hemorrhage within 2 to 4 weeks, and non-compressible vascular punctures, pregnancy, active peptic ulcer, and current use of anticoagulation. Let's move on to the second type, the anticoagulants. And if this patient is planned to go through primary PCI, anticoagulation is recommended for all patients in addition to antiplatelet therapy during primary PCI. So all patients going with primary PCI should receive anticoagulation. Routine use of unfractionated heparin is recommended, and in patients with heparin-induced thrombocytopenia, bivalirudin is recommended as the anticoagulation agent during primary PCI. You can use the unfractionated heparin by using 70 to 100 international unit per kg IV bolus if no glycoprotein 2B3A inhibitor is planned, or 50 to 70 international unit per kg if glycoprotein 2B3A are used. Enoxaparin, you can use 0.5 mg per kg IV bolus before the primary PCI, and bivalirudin, you can use 0.75 mg per kg IV bolus followed by infusion IV of 1.75 mg per kg per hour for up to 4 hours after the procedure. And enoxaparin, and the anticoagulation, if this patient is not for primary PCI and he received fibrinolytic therapy, then also anticoagulation here is recommended, as the anticoagulation is recommended in patients treated with lytics until revascularization is performed or for the duration of hospital stay up to 8 days. The anticoagulation could be enoxaparin IV followed by subcutaneous, and this is preferred over unfractionated heparin, or you can use unfractionated heparin, or in patient treated with streptokinase fondaparinux IV bolus followed by a subcutaneous dose for 24-hour later. So in patient who had fibrinolytic therapy, you can use unfractionated heparin, 60 international unit per kg IV bolus with a maximum of 4,000 international unit, followed by infusion of 12 international unit per kg with a maximum of 1,000 international unit for 24 to 48 hours, with a target of BTT 1.5 to 2 times that of the control. For the fondaparinux, only with a streptokinase, 2.5 mg IV bolus followed by a subcutaneous dose of 2.5 mg once daily up to 8 days or up to the hospital discharge. Moving on to the last one of the antithrombotics, the antiplatelet therapy. It's recommended to use a potent P2Y12 inhibitor, either the prasugrel or ticagrelor, or you can use clopidogrel if these are not available or contraindicated. If the patient before PCI and maintained for 12 months after the PCI. Aspirin, either oral or IV, if the patient is unable to swallow, is recommended as soon as possible for all patients without contraindication. Glycoprotein 2B3A inhibitors should be considered for bailout if there is evidence of no reflow or a thrombotic complication. For the patient undergoing primary PCI, you can use the aspirin with a loading dose 150 milligrams up to 300 milligrams orally, and then you maintain on 75 to 100 milligram per day. Clopidogrel loading dose 600 milligram orally followed by 75 milligram per day, and prasugrel you can use the loading dose of 60 milligram orally followed by a maintenance dose of 10 milligram per day, and a patient with low body weight less than 60 kg, the maintenance dose is 5 milligram is recommended. For the ticagrelor, loading dose of 180 mg orally, followed by the maintenance dose of 90 mg BID. Abciximab IV, it's a bolus of 0.25 mg per kg and 0.125 microgram per kg per minute infusion, maximum 10 microgram per minute for 12 hours. Eptifibatide, you can double the dose of 180 microgram per kg. And for the tirofiban, you can use 25 microgram per kg over 3 minutes, followed by a maintenance infusion of 0.15 microgram per kg per minute for 18 hours. If the patient had gone fibrinolytic therapy, you can use the same loading doses for the aspirin, but for the clopidogrel, the loading dose is 300 milligrams only, not 600 like in primary PCI, and the maintenance dose is 75 milligram per kg. What about the patients having chronic kidney disease? If you have up to stage 4 chronic kidney disease, there is no dose adjustment for the aspirin, the clopidogrel, the ticagrelor, or the prasugrel, but for the enoxaparin, you use 1 mg per kg subcutaneous once daily. But if you are at stage 5 chronic kidney disease with glomerular filtration rate less than 15 mg per minute, you don't have dose adjustment for the aspirin. There is no information available for clopidogrel, ticagrelor, and the prasugrel are not recommended for these patients. For the unfractionated heparin, up to stage 4 chronic kidney disease, there is no dose adjustment, and up to stage 5 also there is no dose adjustment. The fondaparinux, it's not recommended for the patient with chronic kidney disease. either for stage 4 or stage 5. The bivalirudin also is not recommended for patients with stage 4 and stage 5 chronic kidney disease, and abciximab can be used with careful consideration of bleeding risk for stage 4 chronic kidney disease and stage 5 chronic kidney disease. The eptifibatide is not recommended for the patient with chronic kidney disease, and the tirofiban, you can reduce the infusion rate to 50% in patient with stage 4, and for patient with stage 5, it's not recommended to use it. So, after the patient received the initial treatment of the acute coronary syndrome, how to maintain the antithrombotics after STEMI. The dual antiplatelet therapy is the treatment choice for secondary prevention of acute coronary syndrome. This is based on dual inhibition of the platelet activation, with aspirin acting through the cyclooxygenase 1 pathway and the clopidogrel, prasugrel, or ticagrelor blocking the P2Y12 receptors. The current international guidelines advocate the use of prasugrel or ticagrelor as the first-line treatment in patients with acute coronary syndrome, while clopidogrel is restricted to those with contraindications to potent antiplatelet agents, as is the case of those needing long-term anticoagulation. So the antiplatelet therapy with low-dose aspirin, 75 to 100 mg, is indicated, and dual antiplatelet in the form of aspirin plus ticagrelor, prasugrel, or clopidogrel if ticagrelor, prasugrel is not available or contraindicated, is recommended for 12 months after PCI unless there is contraindication such as excessive risk of bleeding. A proton pump inhibitor in combination with dual antiplatelet is recommended in patients with high risk for GI bleeding, and in patients with an indication for oral anticoagulation are indicated in addition to the antiplatelet therapy. In patients who are high risk for severe bleeding complication, discontinuation of P2Y12 inhibitor therapy after 6 months should be considered. So this is a shortened approach after the myocardial infarction if the patient has high bleeding risk. In a STEMI patient with a stent implantation and indication for oral anticoagulation, triple therapy should be considered for 1 to 6 months according to the balance between the estimated risk of recurrent coronary events and bleeding. And dual antiplatelet for 12 months in patient who didn't go PCI should be considered unless there is no contraindication such as excessive risk of bleeding. And patient with LV thrombus, anticoagulation should be administered for up to 6 months, guided by repeated imaging until this thrombus disappears. So, the doses of the antiplatelets for parenteral anticoagulants, if the patient didn't receive reperfusion therapy, like if the patient had came to you very late after 12 hours, then the patient didn't receive reperfusion therapy, he could be used aspirin, clopidogrel, and the aspirin with a loading dose 150 to 300 mg orally, followed by a maintenance dose 75 to 100 mg per day, or clopidogrel loading dose 300 mg orally, followed by a maintenance dose of 75 mg per day orally. And for the unfractionated heparin, enoxaparin, and fondaparin is the same doses as the patient if the patient had received fibrinolytic therapy. So let's move on to the other category of the acute coronary syndromes, the non-ST segment elevation acute coronary syndrome. The main role of antithrombotics here are using the anticoagulants and the antiplatelets. We can see from this graph here that there's different lines of the antithrombotics to work on to stop this milieu of coagulation. There's the tissue factor and the tissue lesion, followed by the coagulation cascade, which is the vitamin K inhibitors could stop, then followed by the formation of the prothrombin, which here the NOACs can work on this, the enoxaparin and fondaparin can work there, and to a certain extent the unfractionated heparin, until the formation of the thrombin, where the unfractionated heparin work, or the bivalirudin or the dabigatran could use and prevent the formation of the fibrinogen and the fibrin. Also the antiplatelets agents like the clopidogrel, prasugrel, ticagrelor, and the cangrelor, the IV form, could be used, plus the glycoprotein 2B3 inhibitor activation to stop the platelet activation. The antithrombotic treatment is mandatory in non-ST segment elevation acute coronary syndrome patients with and without invasive management. Its choice, the combination, and time point of initiation and the treatment duration depend on various intrinsic and extrinsic procedure factors. Notably, both ischemic and the bleeding complications significantly influence the outcome of a non-ST segment elevation acute coronary syndrome patients and their overall mortality risk. Let's move on to the anticoagulants. You can use the unfractionated heparin, 70 to 100 this is before and during the PCI if this PCI is planned for these patients. The unfractionated heparin is 70 to 100 unit per kg IV bolus when there is no glycoprotein 2B3 inhibitor is planned, and 50 to 70 unit per kg IV bolus if glycoprotein 2B3 inhibitors are used. Enoxaparin in the form of 0.5 mg per kg IV bolus. Bivalorudin 0.75 mg per kg IV bolus followed by IV infusion of 1.75 mg per kg per hour for up to 4 hours after the procedure, and fondaparinux 2.5 mg per day subcutaneously only before PCI. This is a topic is new, and this is just published in the most recent guidelines from the European Society of Cardiology in 2020. Rivaroxaban could be used in a very low dose maintenance dose of 2.5 mg BID in combination with aspirin for long-term extended antithrombotic treatment in a secondary prevention in the setting of coronary artery disease patients. So let's move on to the antiplatelets. The activation of the blood platelets and the coagulation cascade play a key role in the initial phase and evolution of non-ST segment elevation acute coronary syndrome. Hence, sufficient platelet inhibition and temporary anticoagulation is essential in non-ST segment elevation acute coronary syndromes, especially in those undergoing myocardial revascularization by PCI. And aspirin is considered the cornerstone for the treatment inhibition of thromboxane E generation, and the dual antiplatelet therapy including aspirin and the potent P2Y12 receptor inhibitor ticagrelor or prasugrel is the recommended standard treatment for non-ST segment elevation acute coronary syndrome patients. Clopidogrel, characterized by the less potent and variable platelet inhibition, and should be used only if prasugrel or ticagrelor are contraindicated and not available or cannot be tolerated due to high bleeding risk. And this is a comparison between the 4 types of the antithrombotics, the P2Y12 receptor antagonist. We can have the clopidogrel, the prasugrel, the ticagrelor, and you can see here that the offset of the effect and the onset effect is different between both of them, but we can see here that ticagrelor is relatively fast, and the IV administration of cangrelor is very fast. It's immediate within 2 minutes of the start of the IV infusion. For the aspirin, the loading dose is 150 to 300 mg orally, or 75 to 25 mg IV if oral ingestion if not possible, with a maintenance dose of the oral of 75 to 100 mg once daily. The clopidogrel, the loading dose is 300 to 600 mg orally, followed by a maintenance dose of 75 mg OD. The prasugrel, the loading dose of 60 mg orally, followed by a maintenance dose of 10 mg once daily. In patient with a body weight less than 60 kilograms, a maintenance dose of 5 mg OD is recommended, and in patient aged more than 75, prasugrel should be used with caution, but a dose of 5 mg OD should be used in the treatment if deemed necessary. No specific dose adjustment for chronic kidney disease patients. Prior stroke is a contraindication to prasugrel, and this is one of the main hindering factors for using the prasugrel in a large scale. For the ticagrelor, the loading dose of 180 mg orally, followed by a maintenance dose of 90 mg BID with no specific dose adjustment in chronic kidney disease patient. The cangrelor, the IV form of the P2Y12 inhibitors, is a bolus of 30 mg per kg IV, followed by 4 mg per kg per minute infusion for at least 2 hours or the duration of the procedure, whichever is longer. For the IV glycoprotein 2B3E receptor inhibitors, we can use the abciximab, the bolus of 0.25 mg per kg IV and 0.125 mg per kg per minute infusion with maximum of 10 mg per minute for 12 hours, and drug is not supplied anymore, so there is some shortage of this drug nowadays. Eptifibatide, you can use double bolus of 180 mg per kg IV given at 10-minute interval, followed by an infusion of 2 mg per kg per minute for up to 18 hours. For the tirofiban, the bolus of 25 microgram per kg IV over 3 minutes, followed by an infusion of 0.15 microgram per kg per minute for up to 18 hours. So, there is a new term called a pre-intervention treatment or the pretreatment, where we can use the anticoagulants and antiplatelets prior to intervention. The pretreatment defines a strategy according to which antiplatelet drugs, usually the P2Y12 receptor antagonists, are given before coronary angiography and when coronary anatomy is unknown. Although a rationale for the pretreatment in non-ST segment elevation acute coronary syndrome may seem obvious, For achieving sufficient platelet inhibition at the time of PCI, large-scale randomized trials supporting the routine pre-treatment strategy in either clopidogrel or the potent P2Y12 receptor antagonist prasugrel and ticagrelor are lacking. So, based on the available evidence, it's not recommended to administer routine pre-treatment with P2Y12 receptor inhibitor in non-ST segment elevation acute coronary syndrome patients in whom coronary anatomy is not known and an early invasive management is planned. For patients with delayed invasive management, pre-treatment with P2Y12 receptor inhibitor may be considered in selected cases and according to bleeding risk of the patient. Unfortunately, the recommended standard treatment with a potent P2Y12 receptor antagonist, the ticagrelor or prasugrel, exhibit a fast onset of action, thereby allowing a loading dose administration after diagnostic coronary angiography while the patient is still on the table and directly before PCI. For the peri-procedural antiplatelets, and mean here by the procedure is the PCI for these patients, today the routine and potent oral P2Y12 receptor inhibitors, there is no compelling evidence of additional benefit of routine upstream use of glycoprotein 2p3A inhibitors in non-ST segment elevation acute coronary syndromes. Patients scheduled for coronary angiography, and nevertheless use should be considered for bailout situations or thrombotic complications, and may be considered for high-risk PCI in patients without pretreatment with P2Y12 receptor inhibitors. For the post-intervention and the maintenance treatment following the PCI for non-ST segment elevation acute coronary syndrome, dual antiplatelet therapy consisting of a potent P2Y12 receptor inhibitor in addition to aspirin is generally recommended for 12 months, irrespective of the stent type unless there is contraindication. And there is some specific clinical scenarios that have been highlighted in the most recent guidelines that dual antiplatelet therapy duration can be shortened to less than 12 months, extended more than 12 months, or modified switching the dual antiplatelets or dual antiplatelet de-escalation. And these decisions depend on the individual clinical judgment being driven by the patient ischemic and bleeding risk, the occurrence of adverse events, comorbidities, co-medications, and the availability of the respective drugs. In patients with non-ST segment elevation acute coronary syndrome and stent implantation who are at high risk of bleeding here defined as precise depth score more than or equal 25 or high bleeding risk criteria met, discontinuation of P2Y12 receptor inhibitor therapy after 3 to 6 months should be considered. In patients at very high risk for bleeding, defined as recent bleeding episode in the past months or planned non-deferrable surgery in the near future, 1 month of aspirin and clopidogrel should be considered. And these are the high risk criteria or the risk enhancer for having a high thrombotic risk: the patient who have diabetes requiring medication, history of recurrent MI, any multivessel coronary artery disease, polyvascular disease, premature less than 45 or accelerated new lesion within 20 years of coronary artery disease, concomitant systemic inflammatory disease like human immunodeficiency virus or SLE, or chronic arthritis, chronic kidney disease with eGFR 15 to 55 milli per minute per 1.7 meter square. Or there's some technical aspects that makes you change your decision, like at least 3 stents implanted in the same patient, at least 3 lesions treated, total stent length more than 60 millimeters, history of complex revascularization like the left main or bifurcation stenting, and history of stent thrombosis on antiplatelet treatments. So let's see this graph. So you have a patient with non-ST segment elevation acute coronary syndrome. You could start with him the anticoagulation for the PCI, either by using the unfractionated heparin or the enoxaparin or the bivalirudin, and then you assess the bleeding risk. If the bleeding risk is very high, you can only keep the patient on aspirin and clopidogrel for only 1 month, and then continue on clopidogrel only for the rest of the time for even more than 12 months. If the patient has a high bleeding risk, then you keep the patient on aspirin and clopidogrel for 3 months. Then the patient continue on aspirin alone for even 12 months or more. If the patient has low bleeding risk, then you assess the ischemic risk. If the ischemic risk is low also, you can keep the patient on aspirin and ticagrelor and for 3 months, and after the 3 months you can continue on ticagrelor only. Or if the patient has low risk but higher ischemic risk, you can use either aspirin or prasugrel, or aspirin or ticagrelor, or aspirin and clopidogrel for 12 months of dual antiplatelet. And if the patient needs, you can continue the dual antiplatelets for more than 12 months. And this is the recommendation from the guidelines in patients with non-ST segment elevation acute coronary syndrome treated with coronary stent implantation with P2Y12 receptor inhibitors on top of aspirin is recommended for 12 months unless there is contraindication. If a second antithrombotic agent added to aspirin for extended long-term secondary prevention for patients who have high risk of ischemic events and without increased risk of major or life-threatening bleeding. And also discontinuation. If the patient has high risk of bleeding, discontinuation of P2Y12 receptor inhibitor therapy after 3 months should be considered. And patient after stent implantation, patient undergoing strategy of dual antiplatelets, stopping aspirin after 3 to 6 months should be considered depending on the balance between the ischemic and the bleeding risk. The last thing that we want to talk about, if your patient have an atrial fibrillation and undergoing PCI for non-ST segment elevation acute coronary syndrome, the default strategy that you go with the triple therapy, either the NOACs and the dual antiplatelets, either aspirin and P2Y12 receptor antagonist for the hospital stay, and then you keep the patient on double therapy, NOACs and single antiplatelet agent. If the patient have high bleeding risk, you continue the double therapy, the NOACs and single antiplatelets for 6 months, then you continue on NOACs alone. If the patient had high ischemic risk, you continue the triple therapy for 1 month, then you continue on a double therapy, NOAC plus a single antiplatelet agent for up to 12 months, and then after the 12 months, the patient is kept on newer anticoagulation or the oral anticoagulation alone. So the conclusions of this lecture that antithrombotics is the key management in acute coronary syndrome, either non-ST segment elevation acute coronary syndromes or ST segment elevation myocardial infarction. Tailoring the risk of bleeding against the risk of thrombosis is sometimes challenging, and dual antiplatelet therapy duration after acute coronary syndrome is affected by many factors and need revision for each patient. And thank you.